Well, thanks for joining me. Again, I want to thank Lynette and Dr. Evidente for asking me to present on this topic. I think it's very fitting since we have Thanksgiving coming up and our gut's going to see a lot of action in the next few days, right? So I think it's very fitting that we have this talk today. So looking forward to exploring that connection between Parkinson's disease and the gut with you. So first off, we're going to understand common symptoms, GI symptoms in Parkinson's. So we want to just go through the objectives for the talk. We're going to try and understand those common symptoms. We're going to learn about the gut-brain axis, what that is. We're going to define that and how the gut and the brain can interact in Parkinson's disease. We're going to understand how those GI issues can also influence your symptoms in Parkinson's disease and maybe even influence your medications in some cases. We'll also consider and review some practical strategies to manage GI symptoms. So moving ahead, just talking about those GI symptoms in Parkinson's disease. So GI symptoms are what are considered non-motor symptoms of Parkinson's disease. And as you all Okay, so as you all know, motor symptoms of Parkinson's, or as you may know, I should say, motor symptoms of Parkinson's are really the tip of the iceberg when we think about Parkinson's. So many of you are familiar with the top four, so tremor, stiffness, slowness, gait disturbance, and balance difficulty. But what's underneath that? When we think about an iceberg, there's a whole mass of ice underneath that, right? So that actually involves a lot of non-motor symptoms that we don't typically think of when we think of Parkinson's disease. And what's circled here are very common GI symptoms. So constipation, swallowing difficulty, gastric pain sometimes can be an issue, gastric reflux. So all of those symptoms really can comprise part of this non-motor complex. And there are a number of other symptoms as well that are part of this non-motor syndrome that we see with Parkinson's. And so non-motor symptoms can start very much before the motor symptoms of Parkinson's. So tremor, stiffness, and slowness may be the presenting motor symptoms. But when I see a patient in the office and we talk about their symptoms, we often think about, hindsight is 2020. What was going on in the years before this tremor started, before the stiffness and slowness and balance trouble started? And very often there are some symptoms that we can point to and view now as part of this prodromal syndrome. So before motor symptoms, there are these prodromal symptoms that can all be non-motor symptoms. So REM behavior disorder is one, which is acting out of dreams. So that can be very obvious to patients and to people, so that they are, falling out of bed or they're kicking and punching. And so the bed partner is going to really notice when that's happening at night. And so that's one symptom that can start 10 to 15 years before the motor symptoms. But constipation is another. So 10 to 15 years before motor symptoms, many of our patients will say, 10 to 15, 10, 20 years maybe, I've had constipation. I just thought it was my gut just not, I'm aging, I'm getting a little bit older, my gut's just not handling things as much as it used to. And we know now that this is actually potentially a prodromal symptom. And so what are the major symptoms that we see with Parkinson's? So some of you may be familiar with some of these, and we can think about this in terms of issues with the entire GI tract. So we can start at the mouth and the salivary glands and the pharynx with the most common symptom, which is drooling, or excessive saliva. And often patients will have their lips sort of parted, and when their mouth is open, then the salivary glands say, hey, we want to take care of this dry mouth, and releases more saliva, and then it's harder to swallow. So it's a combination of the motor control with swallowing, but also the fact that there is a dry mouth often that comes from the lips being parted and oral motor issues. Swallowing problems, so we get into the pharynx and then into the esophagus. You can have issues with that motor control of the swallow mechanism that gets food down into the esophagus instead of down into the airway. And in addition, the esophagus also can pose problems if that's not moving quite properly. So in peristalsis, which is the normal action of the gut, that can actually slow down with Parkinson's. And again, this can all happen even before the motor symptoms start. You can also have spasms at times, air trapping, and there can be reflux. So the normal sort of lock mechanism, if you will, that keeps fluid I just want to make sure. Let's see. You see this pointer that keeps fluid sort of from coming back up. That can be faulty. And so that fluid and whatever you've ingested can actually come back up into the esophagus, and that can cause symptoms as well. In addition, then we've got constipation, and that comes from the bowels not working so well. So again, that motility peristalsis can be impaired. You can have dilatation of the bowels, and then you can actually even have obstruction at times. And even that can lead to bowel perforation. And that is an emergency, a medical emergency. So if you're having sudden pain and unable to pass gas and having a lot of nausea and issues, that's something to definitely go and get checked out for if that's happening. So then finally, we can wind up with anorectal dysfunction, which affects your ability to actually eliminate. And so all of these are the major symptoms that we see with Parkinson's. So how common are these GI symptoms? So there was a study that looked at Parkinson's versus healthy controls to see how often is this a problem for Parkinson's versus, just normal aging, what we all sort of deal with as we get older. And so drooling is the most common here, so salivary excess. And so in light blue, you see the patients with PD, and in dark blue here, the teal is controls. So that's the most common symptom. Then beyond that, constipation and difficulty with elimination is a big issue. That's the second most common. And then you have swallowing trouble. As well as nausea. So, and you can see there in light blue that all of those symptoms are more frequently seen in Parkinson's patients compared to with normal aging. So why there is this connection between the GI system and the central nervous system. So then we need to talk about the gut microbiome. Raise your hand if you've heard about this. And then I heard today that there was a South Park segment that talked about the microbiome. Raise your hand if you've heard of that. I need to find it on YouTube. There we go. There's our storyteller there about that. So anyway, so it's actually pretty interesting and is the topic for not just Parkinson's, but many conditions. We think that gut-brain axis, that communication pathway, if you will, between the gut and the brain is involved in many conditions, and Parkinson's is one of them. So we can think of the vagus nerve as the highway connecting the brain and the gut. So anyone here from the East Coast? Couple? So I-95, you can think of it as I-95. And how about West Coast? So maybe I-5. Is that the right one that goes all the way up and down the coast? And then here in Arizona, maybe the 17. I don't know. So anyway, but this is a highway that really connects the gut to the brain. And that's very important because pathogens potentially and abnormal proteins potentially could travel up that nerve, and things can also go back down. And so that's that communication pathway between the gut and the brain. And so how is the microbiome involved? What is the microbiome, first of all? These are microorganisms that are present in your gut, and we can have them throughout our body, but we're talking and focusing right now on the gut microbiome. So this is basically microorganisms that live in your gut, and they help you with digestion. And they're also very important for your immune system. It serves as a line of defense against things coming in, protecting your body against things that are coming in. Well, what can happen in Parkinson's is that there can be some bad actors, so an increase of those bad bacteria compared to the healthy bacteria. So you have an imbalance then between healthy and bad. And so there's too many of these bad actors. One of them featured here. So in green, we have the bacteria that are compared to controls in present in a larger amount. Akkermansia is one. And I like that name. It sounds like the name of a punk rock band or something, Akkermansia. So anyway, so that's very commonly seen in patients with Parkinson's. And then we have a decreased abundance of good bacteria. So the bacteria that should be protecting us against pathogens and that should be digesting fibers and giving us all those healthy nutrients in processing fiber and things like that. So those in red here are decreased. And then the ones in blue are the ones that we're not quite sure. It's kind of a mixed bag in terms of whether they're healthy or not. But the overall picture is that the balance between healthy bacteria and the not so healthy bacteria is off in patients with Parkinson's. So now we get into what that means. So what that means is that you can have dysbiosis, which is a dysfunctional gut, versus eubiosis, which is a functional gut. And so in the healthy brain, so before someone has Parkinson's, everything's moving along quite nicely. So digestion is giving you all the things that you need. So you've got, let's say you've got good omega-3 fatty acids in your diet. You've got great dietary fibers and polyphenols, and that's giving you healthy bacteria. That also allows you to increase your amount of short-chain fatty acids, which are really important for maintaining the integrity of your gut wall. And it turns out also important for maintaining the integrity of your brain, blood-brain barrier as well. And so the other thing that can happen here in the healthy gut is that you've got antioxidants. So these are things that kind of eat up the pollution that comes from cells working. So these are basically like scavengers and take up free radicals and really keep things healthy for you, keep the environment healthy. Neurotrophic factors, which are nerve producing or growth factors actually for nerves. And then neurotransmitters, so dopamine, oxytocin, serotonin. So all of those things are improved when you have a healthy gut. And then anti-inflammatory cytokines. So inflammation is a big part of what we see in Parkinson's. So then you move over here to dysbiosis or dysfunctional gut, and what happens? Maybe in the diet or because of aging or because your immune system is off or maybe even just your genetics, then you've got an increased propensity to develop abnormal alpha-synuclein, those abnormally folded alpha-synuclein proteins. You have increased saturated fatty acids, decreased short chain fatty acids. That affects the gut wall, and that then in turn leads to dysfunction across, and that gets to the brain. So reactive free radicals, alpha-synuclein, and pro-inflammatory cytokines. So you're really fighting that battle on several different fronts through your gut. And so that is kind of what we view as sort of the first line of defense. And so the intrinsic factors that we reviewed that can influence gut microbiota is genetics, then aging, then the immune system, and then the extrinsic factors, your diet, of course. So we'll talk a little bit about the Mediterranean diet versus the Western diet, environmental conditions. So there have been a lot of studies recently that have looked at the source of toxins that may cause Parkinson's, right? So anyone here golf? Any golfers? Yeah. So there's an article recently you may have seen that looked at folks who may have water sources that are from the runoff potentially from golf courses. So if you live close to a golf course, potentially because of that pesticide runoff, you're exposed to a toxin. Also, in areas of higher air pollution, that also can serve as a toxin. There's a higher incidence of Parkinson's there too. So that's how the environment really can affect your gut, not only your brain, but also your gut. And those two factors together can coincide and result in Parkinson's. And so how does that happen? So this gut microbiome axis is what we're talking about. So that dysbiosis, so dysfunctional gut, leads to increased alpha-synuclein. And that can actually travel through that highway, that vagus nerve, and get up to the brain. It could actually also go down from the brain as well. Again, the leaky gut. So you've got bad actors kind of coming out of the gut. So that gut should be tight and strong for you. But if it's leaky, then you've got bad things going out of the gut and into the bloodstream. And those toxins are not great for the blood-brain barrier, cause inflammation, and that can lead to neurodegeneration. And so all of these factors together essentially can provide that link or cause, in many cases, Parkinson's. So that gut bacteria composition is different, reduced diversity, less anti-inflammatory bacteria, potentially opportunistic bacteria, again, those bad actors, gut inflammation, oxidative stress, which is, again, sort of the pollution that you get from cells trying to function, and then the leaky gut. And all of that leads to protein aggregation and neuronal damage. And so what's interesting is that I mentioned this a little bit before, is that alpha-synuclein, that abnormal protein that we talked about, can actually be found in the gut. So this was the first study in 2012 that raised the question of, can you actually find that abnormal protein in the gut before motor symptoms? So we know that symptoms are starting before. What's happening with the pathology? Well, in fact, this was a study, Dr. Cordewer, who's here at ASU as well. Now, I think he was in Chicago at the time. They studied 3 patients who had specimens in the lab. So they had colonoscopy specimens from prior to their diagnosis with Parkinson's disease, a few years prior. And they took a look at those after their diagnosis to see, hey, can we actually see this in those specimens that we have stored? And in fact, they were able to find that there was alpha-synuclein here, and as well as substance P, which is another we'll call it a bad actor. But these things can be found in the gut, even before Parkinson's motor symptoms develop. So this is our first clue pathologically that there is something going on in the gut. And so this led to the thinking of, well, what happens first? Is it the chicken or the egg? Is it the brain or is it the gut? And so that's led to some discussions and some theories and publications now looking at different clinical pictures or phenotypes. So one phenotype could be brain first. So if you talk to patients, symptoms are all over the place. One patient may have tremor as their only major symptom, tremor and stiffness, let's say, as their only major bothersome symptom. And another patient may have severe gastrointestinal issues, trouble with digestion. Why is that? Why are there these different pictures among patients with Parkinson's? Well, this may be the reason, because the inciting event potentially in the brain first picture or phenotype maybe a toxin or a virus or something that gets in through the olfactory system, through the nose, right? So that olfactory, that the nerve that's involved in smell goes straight to the brain. And so it could travel potentially into the brain first and not go through the gut at all. And then we've got body first. So these are patients that, again, they have a lot of gastrointestinal symptoms even before potentially their tremor, stiffness, and slowness. And what does that come from? Potentially they've ingested something, right? So they've ingested something, maybe genetically their microbiome is not so intact. They've got some unhealthy bacteria in there. And all it takes is one trigger, and then that causes sort of a fire of microbiome changes. It's like lighting a match, right? And so then you have the downstream effects that we talked about: decreased short chain fatty acids, and then increased endotoxins. So bacteria can actually let off toxins as well and pollutants. So you have these bacteria that are actually causing toxins to be released in the gut. That can lead to, again, that leaky gut, akromansia, that's our favorite punk rock band right there, that actually can cause mucin degradation. And so that affects how intact that gut wall is. And then again, inflammatory cytokines, toxins can get into the bloodstream and then go to the brain. And so what about folks in the middle that have a little bit of both? So then there might be sort of a convergence here. So there's potentially things going up and things going down through that sort of main pathway. So we might have alpha-synuclein going from the brain down. And that's why patients who start with motor symptoms and no pre-motor or non-motor symptoms beforehand start to develop constipation over time and start to develop other issues with their gut over time. Perhaps because there is this pathway that goes from the brain to the gut, rather than the body first pathway that has toxins and abnormal proteins going to the brain, but start in the gut. All right, so that's sort of the brain first, body first. A lot of studies in this. There are some folks, especially in Denmark, that are studying this. And so we hope to learn more about this because it really will hopefully, lead one day, we hope, to potential prevention if we learn where things are coming from. Okay, so now let's switch gears a bit. Since we know everything we need to know about the gut-brain axis, let's talk about the GI tract and how it can actually influence your PD symptoms. And we also want to talk about some specific syndromes to be aware of. Okay, so starting off, medication absorption can be an issue. So of course, if you can't swallow pills that are meant to be taken orally, then that could be your first problem, right? So that can happen. And there are some strategies that we can talk about that potentially can bypass the GI tract that we can talk about. In addition, gastroparesis. So we talked about this briefly, but this is where the stomach is just not moving properly and it doesn't get things down into the intestine. So your medications may just be sitting in your gut, and I'll show you a picture of what that might look like. Additionally, there's competition. In particular, with levodopa, it competes with amino acids for absorption across the gut wall. So if you have a big steak, or Thanksgiving when you have that big turkey, if you take your levodopa right with that turkey, is it going to get absorbed? No, probably not, right? So you want to have your medication before Thanksgiving dinner. Make sure, okay? 30 minutes at least. If you can do an hour, even better. But the reason for that is because that levodopa competes with amino acids to get across the gut wall. And so that's why you may have issues if you have it with a big protein meal. It may not get absorbed and you might not feel the beneficial effects. And then we talked about constipation. That can just basically back everything up and prevent absorption across the gut wall, in addition to potentially those other conditions we talked about that might require further attention. And then the other two things that we're going to talk about today, H. pylori infection and small intestinal bacterial overgrowth. These are syndromes that actually can be treated with antibiotics. And so you need the support of a gastrointestinal specialist to determine if this could be the source of your symptoms. But this is something that is often overlooked, and we'll talk a little bit about those. Okay, so starting off with small intestinal bacterial overgrowth. So there are two different types, and I appreciate, I want to call out my patients who have taught me about this, because I didn't really know much about this until I had patients that were seeing GI specialists and were saying, this is my diagnosis. And so really being able to learn about this has been really helpful as I counsel patients in terms of determining what their symptoms might mean. So hydrogen SIBO versus methane SIBO. So hydrogen SIBO basically involves, as it sounds, overproduction of hydrogen gas. And then methane SIBO involves overproduction of methane gas. The symptoms might overlap in some ways, so bloating and such, but with hydrogen SIBO, it tends to be malabsorption and diarrhea. With methane SIBO, it tends to be hard stools, incomplete evacuation, more constipation. And so the treatments vary between the two, potentially. Rifaximin is one that can be used for both, but dietary changes can help with the hydrogen SIBO. And it's something called low FODMAP foods. And so this is not a diet that we recommend for Parkinson's patients in general, only if you have this particular type of SIBO or small intestinal bacterial overgrowth. And there are low FODMAP foods that basically don't provide the substrate that bacteria use. And so these are carbohydrates that are poorly absorbed in the small intestine. And so you want to limit those foods that have those fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. That's what FODMAP sort of stands for. And so that's the idea here, is to reduce the intake of those specific types of carbohydrates that are poorly absorbed. Okay, so those are the two different types of hydrogen versus SIBO, or hydrogen versus methane SIBO. All right, and then let's talk about H. pylori infection. So H. pylori is a bacteria that can cause gastritis and ulcers, and this is common in patients with Parkinson's as well. And one more thing, actually, I wanted to mention about SIBO is for diagnosis. It's certainly clinical assessment of GI symptoms, but there's also this hydrogen or methane breath testing. So this is something that your GI specialist can talk to you about in terms of how to actually diagnose SIBO. Okay, so now getting back to H. pylori. So there is a breath test also involved with H. pylori. There's also a blood test, an antigen test, and a stool antigen test. But the symptoms involve nausea, bloating, loss of appetite, frequent burping, increased motor fluctuations. So this can affect how well your medications are working if you have H. pylori. So if your medications have been working pretty well and then you suddenly develop these GI symptoms and your medications are not working well, this is something certainly to explore with your gastrointestinal specialist. Or you can start with your primary care specialist. Many would start off with some blood work looking at this. But in addition to the urea breath test and the stool antigen test, and upper endoscopy can assess further for ulcers and can actually do samples, biopsies from the gastric mucosa to see if H. pylori could be part of the issue. And treatment here, again, antibiotics. There can be combinations of antibiotics, as well as proton pump inhibitors. So that improves the acid balance in your stomach. And antibiotic resistance can be an issue. So sometimes one round is not enough. Sometimes you need a special 14-day 4 agent regimen to wipe this out. And so this is, again, something that you can talk to your gastrointestinal specialist about in terms of diagnosing this. Okay, so now we're going to switch over to some practical strategies, and just a reminder to, of course, consult your physician for any specific recommendations that might be pertinent to your care, but we're going to talk about some common symptoms and ways to manage those. Okay, so first up, dietary considerations. So what's this all about? Mediterranean, MIND diet, what is the difference and what's the right one? I think as much as you can do to eat whole foods that are, if you think about the rainbow, all different colors, so wide variety, fruits, vegetables, whole grains, legumes, nuts, seeds, that really should be the base of your diet here. So it's a different food pyramid than some of us who are older than what we grew up with dairy kind of being, the solid base, or meats being sort of the solid base. Really, we're looking at other things that should be the base, and it's really primarily plant-based. Olive oil in place of unhealthy fats, moderate fish and seafood, and a lot less poultry, dairy, meats, added sugars. The MIND diet combines that with low sodium, or the DASH diet. And so this is specifically helpful to prevent dementia or cognitive difficulty. So leafy greens is the focus here, berries, limits on red meat, butter, and cheese. And then there's Pro 21. So any of you out there that like to take a look at naturopathic information, nutritional information, Dr. Lori Mishley is a wonderful researcher who has looked at through her Pro PD. It's an app really that patients with Parkinson's can sign up for, and you can basically talk about your symptoms and what you do in terms of your diet. And what she determined from her questionnaires from patients all around the country, actually, I think all around the world, actually, she looked to see, you know, what are the factors that are associated with faster versus slower progression. And what she found was, again, fresh vegetables, nuts, seeds, olive oil, little wine, a little coffee, home cooked meals, organic meals, liberal use of spices. And we think this is probably because of the anti-inflammatory effects of spices. Buying organic, all of that equated to slower Parkinson's progression. And compare that to faster progression in patients who had a lot of dairy, beef, pork, chicken, artificial sweeteners, soda, juice, refined grains, fried food, food from a can, kind of all the things we're going to have in a few days at Thanksgiving, right? And we're not saying never, ever, ever have these things, but patients who limit this do better, and focusing on this sort of aspect can improve symptoms. So it's something to keep in mind in terms of, as you think about what are things that I can do to keep myself healthy, to keep my gut healthy, to keep my brain healthy. This is something to consider. Okay, so let's talk a little bit about fiber and water. 90% of Americans do not consume enough water or fiber. That includes me. So I'm going to have a little water here. So these are the goals that we need to aim for, right? So women over 50 should get 21 grams of fiber. And if you actually start looking at your food content, which I'd recommend from time to time, if you have things all the time, especially, take a look at the content to see how much fiber am I getting with this? You know, how much water am I actually drinking in a day? Here's my water. Thanks for the break. And so 9 cups of water in a day equates to about 72 ounces. A good rule of thumb is take your weight in pounds and cut that in half, and that's how many ounces you should be getting. It's going to be a little bit less than this, but this is all water, right? So other foods may have water, like soups and things like that are going to have water as well. So you don't necessarily have to have 9 full glasses of water in a day, but just make sure that you're getting enough of that hydration in your foods as well. And so that's the recommendation for women over 50. For men over 50, it's 30 grams of fiber and 13 cups of water. Now, if you're only having 2 or 3, I am not encouraging you to go out and have 13 cups tomorrow. Okay. This is something that you want to work towards over time to just make that a part of your sort of daily regimen. And something like this is kind of handy, and it would make a great Christmas present. I don't receive any royalties from this, but this is kind of nice. It kind of reminds you in the day, this is how much water you should be taking. So it's a big jug, and it starts off with good morning and ends with you made it. And, you know, every sip counts. And so a lot of encouragement to keep that water going. But that is very, very important to keep your gut healthy, okay, to keep things moving. Very important. And helps your medications. And it also helps to prevent low blood pressure as well, to keep hydrated. So all of those cups of water in the day are doing something very good for your body. And then, of course, fiber. Here, all these great foods that we can have. Some of these might be introduced in a Thanksgiving dinner, right? Some Brussels sprouts and things like that. Maybe a little berry parfait or something. Yeah, so some of these things can be introduced on Thanksgiving. Not all bad. All right, so then we move to probiotics and prebiotics. This is probably one of the most common questions that I will get is, Doc, what's a good probiotic and what is a prebiotic? So I'm not going to give you the name of a supplement that I'm going to ask you to take, but we're going to talk about some foods that can actually be really good sources. So what's the difference, first of all? So probiotics are live beneficial microorganisms. So these are, again, that good bacteria that we want to keep in our gut. And then prebiotics are the non-digestible fibers that the healthy bacteria need to live. So you want to feed that good bacteria to keep the beneficial bacteria levels up, right? So that's the idea. So probiotics do this directly by introducing that directly to your gut by you ingesting them. And then the prebiotics act as a food source for those healthy bacteria. And so what are those food sources? So for probiotics, it's yogurt, kefir, sauerkraut, a lot of kimchi is a fermented cabbage delicacy, and miso, soy-based, tempeh, kombucha. I actually saw that there's a recipe for tempeh turkey. So if anyone wants to really kind of shake things up at Thanksgiving, you could explore it. I can't attest to how tasty it is, but that's an option. And then kombucha also, again, good source of probiotics. And so these are drinks that you can find now that can really help support a good gut. So it can improve constipation. They can be anti-inflammatory. So these properties can be anti-inflammatory and provide some neuroprotective effects as well. What are some examples of prebiotics? So we've got asparagus, garlic, onions. Again, asparagus may make it to the Thanksgiving table, perhaps. Beans, lentils, nuts, seeds, high quality chocolate. I will say I was excited to see that high quality chocolate, or that chocolate was on here, but it says high quality, which is not the best tasting. It's kind of a little bit bitter, but the high cocoa kind of content chocolates, but which is like the dark chocolates basically. So that's a little more bitter, a little less sweet, but it can go well with some berries maybe. So that's something to keep in mind. And so this actually then can improve constipation, your gut barrier integrity, and has some anti-inflammatory benefits. So this is the story on probiotics and prebiotics and how you can get more of that in your diet. Okay, so let's talk about medication strategies. We touched on this a little bit in terms of when you want to take your levodopa, so 30, 60 to 60 minutes before a meal, 1.5 or even probably better 2 hours after a large meal. And you want to avoid high protein, high fat foods along with your levodopa. And some people have more issues with this than others. I will say I have some patients who will say, you know, even if I have something early in the day with protein, I find that later in the day, my medications don't work as well. So some people are more aware of this issue than others. But as a general rule, it's better to avoid taking your medications with meals. Now, if you have nausea, it is a good idea to take it with something. But what I would recommend there is something like applesauce or graham cracker, something that doesn't have a lot of protein in it if you have some nausea with these medications, because levodopa-based medications can certainly cause some nausea. And so nausea, loss of appetite, early satiety, which basically means feeling full before you really think that you've had a good enough or solid enough meal. And this is a picture here of a carbidopa levodopa pill that's been trapped in the stomach an hour and a half after being swallowed. So it's still sitting there in the gut. And where does that pill need to go to get absorbed? It needs to go down into the intestine, right? Into the jejunum. And so how's it going to get there if it's still sitting there in the gut, right? So levodopa needs to pass through the stomach to get to the intestine. And so this is an example of why you might have gastroparesis is an example of why you might have nausea, why you might have loss of appetite, early satiety, and difficulty with your medications not quite kicking in. You're going to feel full sooner. You're not going to, feel like you want to eat, a lot of nausea. And how do you handle that? So small, frequent meals can help, and low-fat meals can help, and then remaining upright for 2 hours after your meals. So again, Thanksgiving, a lot of references to Thanksgiving. Can you tell I'm hungry? So after Thanksgiving, it's better to go for a walk with your family than to sit on the couch and kind of open up your pants and let everything loose. So get out and go for a walk. Additionally, nausea can be caused by intolerance to medications. So supplemental carbidopa, which is the first part of Sinemet, so carbidopa, levodopa. Carbidopa prevents the peripheral decarboxylation of levodopa, so it allows more levodopa to get to the brain where it needs to go. If that does get metabolized in the periphery, that can cause a lot of nausea. And so the carbidopa actually blocks that from happening and allows more levodopa to get to the brain. So sometimes people just need extra carbidopa to make that happen. So they might have to take a little extra carbidopa. And so Sinemet, little story about that medication name. Anyone here take Latin? Any hands? A couple? So sine means what? Without. What's emet? Emesis? Vomiting, right? So Sinemet. So the medication actually came from two Latin roots, really. So without vomiting. And so that carbidopa was the magic sauce, magic ingredient there to allow people to be able to tolerate levodopa, because initially it was just given without the carbidopa. Okay, and then let's consider also some anti-nausea medications. So things like Zofran can be really helpful. Also, actually therapies that bypass the GI tract. And then as far as red flags, we want to be careful if there's any GI bleeding, weight loss, if there's a family history of cancer. Again, working with your GI consultant is very important to take a look and see what's going on. So nutrition and weight can be a problem. So in those cases, we want to make sure that folks are getting smaller meals maybe, but nutrient dense meals. Consider calorie dense drinks as well, like Boost. And a little trick also is Carnation Instant Breakfast has the same amount of nutrients as Boost and is probably cheaper if you get it in powder form. So you can just get a big thing of it at Costco or Sam's Club and mix it with maybe like a soy milk or almond milk or something, and that's a nice calorie dense food. Just be careful not to take it with your levodopa, again, because it has protein, it might affect the absorption. And then working with a dietitian is also helpful in terms of trying to maintain that weight. Okay, so for excessive saliva or drooling, lots of options here. Working with the speech therapist to work on your motor function is important. Sugar-free candy or gum will keep your lips closed to prevent that dry mouth from happening and to remind you to swallow. There are some medications if it's becoming socially embarrassing or if you're not able to manage your secretions and it's affecting your swallowing, then there are some sublingual agents to think about and Botox, not just for wrinkles. When I do this for patients, they're like, "Doc, this didn't help my lines around my eyes." I'm like, "I'm sorry, it's not diffusing that far, but it does help with excess saliva." And so swallowing difficulty, what we have here is an example of a swallow study where you you ingest something that is barium coated, different textures, and the speech therapist with the radiologist can actually see if it's going down the right way and what's happening. Are there spasms happening? Is there constriction? And that gives us information on what's happening and why the swallow issue is occurring. You can manage this again, swallow therapy. Shout out to our speech therapist. Raise your hands back there, speech therapist. Woohoo! Swallow therapists, you do great work. Thank you for working with our patients. And so these are helpful. Endoscopies are done by GI specialists, and they can determine if there's other issues like the esophageal issues going on where you might need to stretch your esophagus if it's too narrow, for example. Managing constipation. Fiber fluids, we talked about that. Toilet routine. There are some over-the-counter agents like Miralax. There are some prescribed agents like Amitiza, Linzess. I learned about Metegrity as well from a patient of mine. And did you know that there is an actual tea out there that has senna, which is a laxative, and it's called Smooth Move? I think that's really interesting. Very clever. But other things that you can also do, abdominal massage, acupuncture, again, Botox potentially if the issue is a sphincter issue. And so practical daily checklists. So we're almost done here, just in terms of thinking about some things that you want to keep track of, your bowel movements, your swallowing changes, keep a medication diary, lifestyle tips for gut health that we talked about today, keep those in mind, report any sudden changes to your care team, make sure, and those sudden changes, severe constipation, unexplained weight loss, your medications aren't working, new swallowing or coughing after meals. You can bypass the GI tract with some strategies. Our friends here that were sponsors, want to shout out to them. A patch is a dopamine agonist that can bypass the GI tract. There still can be some nausea there, but you might get a little more continuous benefit. Inhaled therapies or rescue therapies bypass the GI tract and work for about an hour each. So Inbrija and Apokyn, and now we have a subcutaneous infusion called Anopco, and there's also subcutaneous infusion of Viala or phoscarbidopa, phoslevodopa. There's also Duopa, which is intrajejunal delivery, so it involves a G-tube that allows an intestinal gel, levodopa intestinal gel, to get straight to the jejunum. And then finally, if you're having issues, your medications aren't working, medications are causing a lot of problems, a lot of GI issues, what can you do if you're still having symptoms, motor fluctuations, dyskinesias, tremor, your medications are just not quite cutting it? You can bypass that GI tract and maybe get to the root of the matter with deep brain stimulation and focused ultrasound. So these are strategies that focus on the brain and actually focus on sort of turning down the volume in parts of the brain that are overactive as a downstream effect from that loss of that motor circuitry function. And by doing that, you can actually reduce the major motor symptoms of Parkinson's disease. And so current research, as you saw, most of the treatments now are symptomatic, but studies are underway looking at the gut-brain axis, the gut microbiome, even alpha-synuclein biopsies of the GI tract. So that early study still looking to see if we can find, that was just regular alpha-synuclein. What about the abnormal type of alpha-synuclein? Can that be found in the gut as well? So there's more work in that area. Some microbiome targeted therapies, so pre and probiotics, fecal microbiota transplants, which is being done in cases of C. diff colitis, but maybe a potential therapy for Parkinson's as well. And that's a way to, again, improve that healthy balance in the gut. Antibiotics for the infections we talked about, H. pylori, SIBO, more research there, and potentially disease-modifying treatments to slow the underlying degenerative process. Here are resources and supports for you. So again, team-based approach, GI specialists are very important to determine if there are some other conditions that require different treatments that your neurologist may not be able to provide you with. Dietitians, very important to help you with what you can do as far as your diet if you're having issues with weight or constipation, and that is continuing and affecting your quality of life. You want to work with some dietitians, speech and swallow therapists. Again, raise your hands, woohoo! And then organizations, the patient-based advocacy organizations, PMDA, APDA, Parkinson Foundation, Michael J. Fox Foundation, Davis Finney, Brian Grant, MDFA. Shout out to MDFA. Thank you, MDFA.